Hello.
Hello. Good
Yes,
evening.
sir.
Yeah,
Good evening.
yeah. We'll wait for 2 more minutes and then go.
When open, we can start the session, sir, whenever you
Yeah.
want.
Okay. Thank you. Okay, we will start. So, good evening to all of you. I will, as usual, I start with a short case first. So, is my screen visible to you all?
Yes, sir.
Yeah. Okay. This is the story of a 74-year-old lady. He came with a history of imbalance while walking for the last 3 months. No particular worsening at night. No history of a limb incoordination or slurring of speech. No paresthesia of the limbs and no other complaints. In fact, 3 months history of imbalance while walking, no other complaint. This is a video of the patient. There was no nystagmus I could make out. The ocular movements appeared normal. Lower cranials were normal. Speech was normal. Motor system power normal. There is no incoordination of the limbs. Lower limb power also normal power. The reflexes were normally elicited. Angle is also normally elicited. Plantar was downgoing. There is no lower limb heel shin test was negative.
കൊണ്ടുപോവാ ഇനി താഴെ മുട്ടിക്കമ്മ ഇനി ഇവിടെ കൊണ്ടുവയ്ക്ക് താഴോട്ട് കൊണ്ടുവന്നേമ്മ മതി ഇനി താഴെ മുട്ടിച്ച്
No incontinence the lower limb I could make out.
താഴോട്ട് കറക്റ്റായിട്ട് കൊണ്ടുപോകാമ്മ ശരി മതി ഗിരിപ്പ് അറിയാമല്ലോ
Vibration sense is normal.
ഇതും അറിയാം ഒരു
Joint sense is also normal.
ഇപ്പോഴോ 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 കറക്റ്റ് അതേപോലെ ഈ കാര്യം കൂടെ പറയണം ഇപ്പോഴെങ്ങനെയാ ഇപ്പോഴോ ഇപ്പോഴേ ശരി.
If she is correctly, rhombox is very positive, not very convincing. Mild worsening on eye closure, but still able to stand without falling. Gait was normal. But tandem walking was grossly defective, tend to fall to either direction. That's the finding. Tailness normal, no nystagmus. Motor system normal, sense system normal, ETR normal, plantar flexor, rhombus is mild abnormality. Gait normal, tandem walking was defective. So, what is a localization and probable etiology? 3 months history.
Vestibular.
Pardon?
Vestibular.
Vestibular
Bilateral
mean-
vestibulopathy.
Okay, bilateral vestibulopathy. Good, very good. Any other possibility? Can be vermin lesion. Inferior vermin lesion, procranial lobe lesion. Why not try procranial lobe lesion?
Floccular lobe lesion, sir.
Yeah, that's also possible because it can produce gait ataxia without any limb incoordination. So that's one possibility you have to keep in mind. Bilateral vestibulopathy agreed. So what do you want? What do you want now? MRI brain?
MRI.
So probably this patient already came with the following investigations. The MRI brain was entirely normal. There was no unnodulated malformation. Cerebellum was normal. And she had audiometry test which showed bilateral high frequency hearing loss, maybe age-related, we do not know. So what do you want me to do now?
VOR.
Pardon? VOR is normal.
Head impulse test.
Pardon?
Head impulse test.
Very good. Head impulse test. Okay. Why do you want to do head impulse test? Because you have to look for bilateral vestibulopathy, correct?
Yes.
Yes. Yeah. What do you expect in bilateral vestibulopathy? It will be positive on both sides. Yeah, bilateral positive. Perfectly right. So head impulse test was done. This is the head impulse test. Tell me.
വേറെ എവിടെയും നോക്കരുത് കേട്ടോ ഇവിടെ എവിടെയും നോക്കരുതേ
That is normal, but on
എവിടെയും
tilting to the right side, there is positive, but tilting to the left side, it is negative. He is able to keep on my face, but looking to the right side, it is positive.
ശരി കേട്ടോ
So
വേറെ
what is the diagnosis? Vestibular ataxia. Okay, but unilateral vestibular nerve affection will not produce ataxia. At the most, acute vestibulopathy can produce transient imbalance in stance and mild ataxia with tendency to fall to one side, but it usually lasts for only 3 to 5 days. It will subside even after your nerve is cut on one side because of central compensation. So, where do you stand now?
Phobic vertigo.
Pardon?
Phobic
vertigo, okay, could be considered phobic vertigo, but to call phobic vertigo, they usually it should be long duration. Second, you should exclude all other causes before ruling out public. But he has got, here we have got one positive sign. Head thrust is positive on one side. So
We
it is
can check-
any that, pardon?
We can check the head thrust which appears normal in slow motion.
No, normal slow motion can occur in pursuit system is in, it will be normal in slow motion. Even if
No,
head thrust is positive,
slow
it
motion,
will be.
slow motion recording. Doing
Oh,
it
okay, okay. Slow motion recording on the opposite side you want to mean. Okay,
Yeah,
that
to
I
make
did
sure.
not do. Yeah. I'm a only clinical examination is the one which I always go for. So that recording is not, I don't have facility for recording that. But it was it is perfectly all right on the other side. Looked all right. But as you said, there may be a subclinical or mild abnormality on the contralateral side, may be there. Any other test which you can do on the bedside.
Fukuda's test, sir.
Pardon? Fukuda again will show only a deviation to one side. So what we want to know whether the opposite labyrinth is affected or not. We know one side is affected. We know whether the other Vestibular or labyrinth is affected or not. Okay, this is what I did.
Supine roll test, sir.
No, that's not going to help us at all. What will you do to find out the opposite labyrinth is also not functioning properly? Caloric test. Okay. Always think caloric test is a more powerful test than VOR. Okay, head thrust test is a more powerful test. So this is on the left side, there is clinically unaffected side.
തണുപ്പ് പോലെ വരും കേട്ടോ.
You can take nystagmus beating to the right side. That is what you expect in cold calorie test. Look at the eye now. It usually starts within 30 seconds. It is beating to the right side.
This is the normal response. Nystagmus beats to the opposite side.
It lasts for 1 minute, 45 seconds. It subsided, gradually came down and then stopped. Then the other side, the affected side where we got the positive head thrust test, calorie test was done. You want to make sure it is totally damaged or not. There is absolutely no response from the right side. There's no nystagmus on calorie test on the right side, only on the left side.
വെള്ളം നനഞ്ഞ് തണുപ്പ് തോന്നിയോ? മുകളിലോട്ട് നോക്കമ്മ.
So canal peral is on the right side. Normal, is it normal on the left side? Appears normal, no? But a good nystagmus response. But the duration nystagmus less than 1 minute. Usually with ice cold test, the nystagmus should last for more than 2 minutes. Here it is decreased. So it is hypoactive, not totally lost. So most likely he has got a bilateral, as you already told, bilateral vestibulopathy. Its more affection was on the right than the left side. The idea was this case was brought because you are in doubtful cases, you do always confirm with the caloric test. Okay, any questions in that case?
What is the temperature used of the water High school.
Usually use conventionally you should do 7 degrees above and below the body temperature, but here you use only the ice cold one.
Is there any risk of bradycardia?
I don't know. I have been doing it regularly. I have not seen any problem with that.
Okay.
Yeah, there's a possibility. I do not know. There is a possibility because that area is also separated with the sensory branch of the ninth cranial nerve. Okay, shall I go to the next case? So the point is when you got somebody who's got a tandem walking defective, all other things are normal. There are two possibilities. One is flocranodular low lesion or a bilateral vestibulopathy. The history of task in a bilateral vestibulopathy is oscillopsia. Retrospectively asked about oscillopsia, she was telling about, she did not volunteer it. When asking, she said, traveling in a bus, the things used to move up and down. That is one point, tell you that it's a defective VOR bilaterally causing oscillopsia. Second thing, always do head thrust bilaterally, head thrust test should be absent bilaterally. If not, do cold cavity test. In the case of flocranodular lobe, it's extremely difficult to differentiate from other conditions. The only finding will be gait ataxia, but the clue is that usually that lesion is associated with nystagmus. Various types of nystagmus can occur with flocranodular lobe, but this patient did not have any nystagmus. That's also a point against a flocranodular lobe. These are the two clinical points. Both of them will not have any limb ataxia. Okay. Shall I go to the next case?
Yes, sir.
Okay. It's a story of a 71-year-old. Pardon, any questions? Please ask.
Kinetic drum, will it help?
Pros, I did not hear you. Can you?
Kinetic, this thing now, your drum now with the tape and all, can you identify that?
That's for optokinetic testing. That will not help.
Will not help.
That cannot help. That does not involve the labyrinthine system. There is a pursuit system and the saccadic system, and the center is in the parietal lobe, PTO junction. But the pathway involved, brainstem as well as cerebellar connection influences that, but labyrinthine lesion will not affect that.
Oscillopsia can be seen in cerebellar lesions.
Oscillopsia is classically any lesion producing absent VOR can produce oscillopsia. There are, in fact, there are two types of oscillopsia. One is the one which you see in lost vestibular reflex is that the oscillopsia occurs when the patient is walking or traveling in a vehicle. When your body is moving, the patient cannot fix the eye on a target. The targets will appear moving up and down. That's oscillopsia which you get in a absent VOR. Or if you find any saccadic intrusions or downbeat nystagmus can also produce oscillopsia. That oscillopsia occurs when the patient is static. If the patient is not walking, you find something is moving up and down. That make you suspect that patient has got some involuntary ocular movement abnormality in the form of nystagmus. The usual type of nystagmus producing oscillopsia is downbeat nystagmus and acquired pendular nystagmus. Because during saccadic portion of the ocular movement, the vision is suppressed. So it is that the usual nystagmus produce that thing. Or some other saccadic intrusions can also produce oscillopsia.
Okay, thank you.
Okay. The fluid differentiate is that is the oscillopsia occurring while walking or not walking when the patient is stationary. With stationary, think of conditions like superior oblique myokymia, as already told, downbeat nystagmus, things like that. If it is no nystagmus, nothing, but if an oscillopsia means invariably, most likely it is a absent VOR bilateral. Okay, this is a story of a 71-year-old man. It's an old case of diabetes and hypertension for the last 20 years. He still slowness in walking and dragging of the right leg for the last 2 years. The walking difficulty, according to him, is remaining like that. They remain the same without either improvement nor any progression. For the last 1 year, he complained of numbness of feet, both feet, for the last 1 year. He's still loosening from the chappals from both feet for the last 1 year. Precipitants in micturition for the last one. So I'll go back to the history once again. Chronic diabetic and hypertensive, slowness in walking with the dragging of the right leg for 2 years, which remains the same. Numbness of both feet for 1 year, loosening of the chapels from both feet for the last 1 year, and precipitancy for the last 1 year. This is on examination. Painless were all normal. The tone power was normal in both upper limb. Power was also normal. There is no incoordination of the upper limb. There is mild wasting of the thigh bilaterally more on the right side. And also, I forgot to mention, it's got pain in the knee also. There is no obvious spasticity I could make out by lying down. Hip flexion was normal. Knee extension also normal. Abduction was normal power. Adduction was normal. Hip extension is also normal. Dorsiflexion angle is normal. But EHL was normal on the left side. But weak on the right side. That is weak on the right side. Flexor paralysis longus was normal. Plantar flexion normal. Come to the reflexes normally elicit in the upper limb. Sorry, left triceps was decreased. Left triceps is absent. Right was very elicited. Right was normally elicited. That's right triceps. That is absent on the left side. Finger pressure was also absent bilaterally. And sometimes may be absent even otherwise. Knee jack right side is slightly brisk side or well elicited. Left knee is absent. That is brisk compared to the left side. Both angle jacks were absent. He's a diabetic for 20 years. Abdominal reflex were intact. Plantar was most likely upgoing on the right side, not very left side is definitely flexor. But right seems to be upgoing because never it went down. Occasionally it is going upgoing. Whether it's withdrawal or not, I was not sure, but most of the time it is going up. Test sensation is normal. Vibration is normal. Normal both upper and lower limb. Is it correctly in the upper limb? That is impaired. Made a mistake. Again made a mistake. Is it down? Left toe was normal. This is the way he walked. He's dragging the right lower limb. There's some suggestion of it dragging on the left lower limb as well. Rhombox was negative. Mildly positive. He could stand without falling. So this is the story of the patient. Mild wasting of right quadriceps. He had osteoarthritis in the right knee. Normal tone in the upper limb. Tone appeared normal while examined when the patient was examined while lying. But he was dragging his both lower limb while walking. It was much more prominent on the right compared to the left side. Power, motor system power of the upper limb normal. The lower limb all normal except for the weakness of the right extended sacroiliac longus. DTR upper limbs both biceps normal, triceps normal on the right side, absent on the left side. Both finger flexors were absent. Lower limb knee jerk, right knee jerk is 2+, normal or plus we can take whatever way you like. Left is anyway absent. Both angle jerks are absent. Abdominal reflex is normal. Plantar right looked extensor, never went down. Left was briskly going down. That means occasionally it is, most of the time is going up, occasionally it was remaining without any response. Sense system test pain normal in both upper and lower limb. Vibration normal in both upper and lower limb. JPS normal in the upper limb, impaired over the right big toe. The limb with a toe with weakness. Normal in the left big toe. Romberg's mildly positive, gait spasticity of the right lower limb while walking. He was also dragging the left lower limb to some extent. It is up to you to conclude his spasticity or not. But on the exam in the bedside, I could not make out any spasticity. So this is a story. Any clarification in the findings, you can ask me.
Sir, any fasciculations?
No fasciculations. This stiffness in walking has been there for 2 years. He also complained numbness of both feet, precipitations in micturition.
No neck pain or radicular pain.
Yeah, that's a good question. But he never complained. I asked for that because seeing the absent triceps reflex on the left side. But his weakness, dragging was more on the right side and right. It is a right plantar which is upgoing. Still, we have to ask that question. I asked that he never complained of radiating pain along the upper limb at all. No pain anywhere except for the right knee joint. That is his complaint. Okay, what do you know?
Left knee jerk is absent, sir,
Left knee jerk is absent.
but without any weakness.
Without any weakness was not there anywhere except that he has got right EHL is the only muscle which is weak. All the muscles will be normal power.
The left lower limb looked externally rotated.
He is walking like that. On walking,
Yeah.
that's not okay. I did not think it's abnormal. Walking with external rotated limb on the right side.
While lying down, his left limb looked externally rotated.
Yeah, but the power was normal.
Normal. Okay.
Yeah, okay.
Mainly element findings only. So except for
Yeah.
doubtful plantar.
Yeah.
Plantar is extensor.
The problem is the side with upgoing plantar has got a brisk knee jerk. So there are things, some suggestion of a human also, because even though there is a doubtful plantar, that is asymmetrical. That's more, it was, if at all is upgoing on the right side, the same side has got a brisk reflex, and it's also dragging the feet on the right side.
Yeah, the gait looked like a spastic gait.
Yeah, so that means that has to be given significance.
So yes.
Yeah.
You have to include two lesions, sir. One at the cervical level, or maybe the lumbar, the first possibility, sir. Maybe radicular neuropathy, myeloradiculopathy.
Okay, maybe most likely cervical or thoracic. It has to be above L1, no? Right lower limb is spastic means. Spasticity means above L2 level should be there on the right side.
In view of upper limb decreased triceps, maybe cervical.
Yeah, right.
Concept.
Perfect. That's the first thing you have to get. I also thought that's the first localization. Correct. Okay, so what do you want now? Let us see.
Reflexes are intact, no, sir.
Pardon? Upper limb reflex are, I did not get you.
Abdominal.
Abdominal reflex is intact. But sometimes, it has some spondylotic myelopathy. Abdominal reflex can be retained. I have seen many cases like that. Need not be absent all the time.
Cerebral palsy also abdominal reflexes can be.
But as you said, it may be in the dorsal cord also.
Sir, but dorsal lumbar, sir, because the left thigh wasting is there and the reflex is absent on left side.
No. But left thigh was not wasted. Right knee here, the
That is
osteoarthritis.
disuse
of the knee.
wasting.
Yeah, you got osteoarthritis of the right knee. That may be the wasting response. So that reflex is brisk. No, on the left side, left knee jack is absent. That is agreed.
So you have to consider lesion at lumbar also, no? Or maybe diabetic, sir.
Maybe.
Diabetic neuropathy with the dorsal cord lesion. Maybe.
Yeah, right. No, that's what your point is well taken. See, an absent reflex by itself, with the normal power, I think should not give much of importance. But we had not seen his reflexes earlier. He's also a diabetic person for long. But if it's you've got a weak limb or a spastic limb with or a stiff limb with a brisk reflex, that has to be given significance. The left knee jack, as you said, may be a radiculopathy, may be there. Sometimes we do not know where it was absent before, also we don't know. For example, a finger flexion was also absent. Okay, this is my word, but your point is well taken. So we have to keep either a lesion in the, because my pyramidal lesion is there. So you have to think of a myelopathy, whether it's the dorsal cord or the cervical cord. But he has also got precipitancy and mixturation dragging on the left leg as well. Okay, so that's the possibility you have to keep in mind. So site of cord affection, chorithoracic, as you said, choricervical. Chori left radiculopathy in view of the absent triceps reflex with the normal right triceps. But again, that's a little odd point because pyramidal weakness on the right side, the triceps reflex absent on the left side. So it's a little confusing. But anyway, we want an MRI or the dorsal cervical spine. You agree with me?
Yes, sir.
Okay. So let us see the MRI. This is cervical and dorsal MRI sagittal cut T2. Normal MRI. Then I'll show the T1. I'll show the cervical and dorsal T2 axial. Going below, up from, going down from up downward. There is no cord lesion, cervical cord lesion seen. There is a dorsal cord. Again, there is no lesion seen in the dorsal cord. Again, went up to the cornus region, epicornus region. That is the lowermost part of the caudicus cornus region, epicornus caudicus. So whole cord axial, it was normal, no hypertension seen anywhere. So I took a thin cut of the sagittal, cervical dorsal thin cut. And I could not make out any abnormality in the cervical dorsal cord. This is the T1 weighted again. There is a T2. Thin cut again normal, no abnormality in the cord could be seen. So MRI normal.
Lumbar, sir, lumbar.
Lumbar was done later, but that cannot explain the findings, no? The pyramidal findings in this patient.
So, but the right foot EHL is weak, but FHL is normal. Could be L5 also, no, sir?
Could be an L5 radiculopathy also.
Lumbar MRI should be taken, no, sir.
The thing is, suppose you find something in the lumbar lesion, disc collapse or something, but how to explain his findings? See,
The gait is not clear-cut spastic, no, sir. Some doubtful spasticity is there, not clear-cut spasticity.
No, we are not, I agree with you. He's dragging the foot. Definitely he's dragging bilaterally
So
more
in
on the
view
right
of the urinary symptoms and the UMN signs on the right lower limb, could it be a left frontal lesion?
Yeah, but that's a good question.
Yeah,
But only point is that he has got left lower limb also got some dragging on the foot. And precipitancy means bilateral lesion should be there. Okay, what do you want now?
MRI brain.
MR lumbar, sir.
Okay, but MR lumbar, I agree with you, but suppose you want to explain that EHL weakness due to radiculopathy, perfectly agree with you. But his main problem is not that. He's dragging for the last 2 years, he's dragging the low. That is his complaint and slowness of gait and precipitancy. That you can't explain by a radiculopathy.
Maybe
Brain
caudal
MRI.
lesion above L1, sir. Caudal lesion above L1.
Yeah, correct. That lesion above L1 means in the dorsal cord. Okay. Now let us see the MRI of the brain. This is the diffusion. Yes, hydrocephalus. And if you look very carefully, there is a T2. It's multiple small infarct, but major that's on the thalamus, on right side also. And another big one on the left coronary. That's the infarct there, which you can say also the static. And it's also got a hydrocephalus. This is the flare. There is an old infarct there on the left coronary radiator. This is the SWI. There is no microbleeds or anything in there. This is a flare sag, thin cut. Hydrocephalus and multiple small infarct can be seen. So he has got NPH, hydrocephalus is there, that could explain his some of the symptoms. And multiple infarct, main one was the left coronary radiator. I will show that infarct. This infarct, which is hydrocephalus infarct there. And SW shows, flare shows that it is hypointense because indicating a cavitation of the infarct, old infarct. Now you have to, how do you explain his findings now with this MRI? Yes.
Not all can be explained, sir.
What all we can explain with this MRI finding?
Only bladder we can explain. Some part of the gait we can explain.
Yeah, we can explain the gait of spastic, dragging on the feet, and bladder involvement can be explained by the hydrocephalus. But the asymmetrical right lower limb spasticity, you can explain by the infarct. He has got infarct on the left coronary radiator. And from the history itself, we are telling it has been there for 2 years and static. Okay.
So one doubt, sir.
Yeah.
So the right foot EHL is weak now, sir, but flexor hallucis longus is normal. Can you get in the infarct, sir, that gross abnormal?
That's literally odd, very odd. Because
and
if you
GPs also is in joint position.
Theoretically, it is possible because between the two, the maximum effect will be EHL compared to the EHL compared to the FHL. Because the dorsiflexion will be more effective than the plantar flexion. A subtle pyramidal lesion, you can stretch your imagination, think of pyramidal lesion, but as you said correctly, very difficult to explain. EHL alone weakness and moreover impaired JPS sensation of that big toe. And difficult to explain with an infarct. But the spastic weakness on the right side can be explained by the infarct. Dragging on the feet can be explained by that. So NPH can explain short-stepped gait and precipitancy, and left coronary infarct can explain the right side pyramidal weakness and dragging more on the right side. Now, this is the golden question. What is causing his weakness of the right EHL and impaired JPS on the right big toe?
Diabetic.
Pardon?
Diabetic sensory motor polyneuropathy.
I did not get you, but what did you say?
Diabetic sensory motor polyneuropathy.
Yeah. But the diabetic one, you're thinking mononeuropathy, correct? You're thinking in terms of a nerve involved. Yeah, correct. It could be nerve root also, correct? It can be root, yeah, it can be L5 radiculopathy or it can be a common peroneal involvement. So that's it's odd for a localization, can't be explained by the cerebral hemisphere lesion. Okay, so what do you want me to do?
Narrow conduction.
Narrow conduction studies.
Okay. See, is it also the same question you asked? Is it part of pyramidal sequence? Less likely. Then could it be an unrelated peripheral problem like L5 radiculopathy or mononeuropathy of the right common peroneal nerve? Because the other point favoring is reflexes are also diminished, but that you can argue he has got diabetes mellitus, yes. That's not a strong point because it is absent on the other side also. So NCS was done. Whether we find our idea was to whether it's LM lesion on the right lower limb in addition to the spastic weakness of the right lower limb. This is the LM NCS. Right conperoneal amplitude is half of what is on the left side. Amplitude is decreased on the right side. NCS sensory conduction, sensory potentials were normal, both supraperoneal. If you put prolonged on the tibial, not on the peroneal. Okay. So what is an inference now?
Maybe a root lesion, sir.
Correct. So that means he has got it has been for long duration. No, it's naturally expect a snap to be absent if it's a peripheral nerve problem. Since it's got absent JP sensation of the big toe, but snap is preserved. So that means it's likely to be a root involvement, which can explain the sensory motor dissociation in the sense that the snap can be preserved and the lesion is proximal to the ganglion. And motor system, CMAP is decreased due to lesion anywhere in the root or periphery, it can be decreased. And the other indirect clue is that his tibial FA response is prolonged, indicating again with a normal peripheral conduction, indicating probably a proximal lesion of that roots also. That is clinically unaffected, but that may indirectly indicate that there may be a proximal involvement of those S1 root also. You got the point, because it's got a tibial FA is prolonged. Okay. So SNAP is normal. So mononeuropathy is less likely. Could be radiculopathy causing decreased CMAP amplitude. What else will you like to do? Navina lesion is likely to be in the root.
Reflex.
Okay, H reflex. H reflex is mild delay on both sides, not contributory. Moreover, now H reflex is going to detect only S1 root or tibial nerve involvement. Our lesion was L5 root. What will you do? You have to explain. Right. You have to do for MRI the lumbar spine. Okay, this is MRI the lumbar spine. Sagittal cut. It shows this prolapse L4, L5, and L5. But that is, you can see if we look very carefully, some migration of the disc is there here. And you make out that migration a little bit here. But this is not a proper view. You have to get in a proper axial cut. In fact, this MRI LS spine was not the one which I did not do it subsequently. It was part of the previous study. I did not ask for a lumbar spine in the first view. The first consideration was, as you all thought, MRI of the dorsal spine and the cervical spine. When that came negative, I looked for a brain. Brain could explain some of the things, but that cannot explain the weakness. Then I thought, why not do a lumbar spine? But lumbar spine sagittal was already there. This is a MRI, we just not doing a disc, which I saw earlier, but did not give much of importance because the pyramidal lesion was more dominant. So this prolapse between L4, L5, and L5S1, but we need axial cut to confirm the same. So what do you want? Again, as I go to the MRI scan and do the axial cut. But this could not be done since patient is very reluctant to go to the MRI once again. Because in the first instance itself, he was very, very reluctant. He had to be sedated and because so much claustrophobic. So you said you will not go for the MRI once again. So what will you like to do?
EMG, sir.
Yeah. So do the EMG now. Let's see whether EMG is going to help us. EMG from the belly side and both sides were normal. No spontaneous activity, normal recruitment. That is on the right side. Left side also same. Compared with that, same sort of same, no spontaneous activity. Okay, that's also normal. So what is the final diagnosis? EMG can be normal, no? Because it's got only H5 radiculopathy may affect only the extensor longus. I did it from the tibialis anterior. So there is definitely LM lesion there, but I could not confirm the other muscles are affected. Okay. So what is the final diagnosis? NBH causing short-stepped gait and urinary incontinence. Old left coronary radiating infarct causing right lower limb pyramidal weakness and spasticity. Right L5 radiculopathy causing EHL weakness and impaired JPS with the right big toe. Okay. You agree with these possibilities?
Left triceps reflex was also absent.
That is absent, but we could not, I could not get any reason for that. Now, what happened means many times there may be a exit, that there may be a disc protrusion or a root canal stenosis, and that area can produce absent reflex. In the nerve root compression, the first symptom will be only absent reflex. That is, many old cervical spondylotic persons, you find absent reflex in the upper limb with no complaint in the upper limb. No sensory complaint, no nothing. No, you are not pain also, but the reflex may be absent. If you take an MRI, you find severe spondylotic changes. So it's not that the lesion may be only compressing at the root entry level. It's not root entry level, that the foraminal level. Then it can be easily missed in an MRI.
Can diabetes produce, sir, asymmetrical triceps? Can diabetes produce?
No, the asymmetrical triceps cannot be occurred by cannot occur with the triceps with diabetes. Because in diabetic neuropathy affecting the upper limb, it's not the classical distal symmetrical neuropathy in the upper limb is very uncommon in diabetes. What you get is a mononeuropathy like a carpal tunnel syndrome or ulnar neuropathy. Pressure pulses are more common in the upper limb than diabetic neuropathy, rather than a symmetrical neuropathy as you get in the lower limb. When you get a significant symmetrical peripheral neuropathy in the upper limb in diabetes, think away from a classical diabetic neuropathy. Think of something like a CADP or some other condition. If it is an ulnar nerve or nerve distribution, agree. That part is different. Carpal tunnel.
Okay, sir.
So the left knee diminished reflex is due to diabetes, sir.
Left
knee reflex is diminished now, so that is due to diabetes.
Yeah, most likely you may be having an underlying diabetic neuropathy on which he had a pyramidal lesion on the right side. That produces a disc reflex.
Diabetic neuropathy produce an absent major.
Pardon?
Diabetic neuropathy can produce an absent major.
No, that's not what I said. Suppose he's got imagine that this patient did not develop a pyramidal weakness on the right side. His reflexes, knee jerks were absent, knee jerks were borderline or absent. That patient develops a pyramidal weakness on one side. What will happen to that knee jerk? Unless it is totally fibers are totally lost, that knee jerk become brisk or well elicited. Okay. Now, there is one explanation. Or you can think that the left knee jerk is due to another radiculopathy affecting L4 on the L3, L4 on the left side. That's the only way to explain. Since he has got absent angle check also on the opposite side, both sides is absent, that means he has got a peripheral neuropathy. Otherwise,
So
he's got the multiple route involvement.
So the gait in NPH usually says short steppage gait. So here it's slightly
Correct.
wide baseness. So
Right. NPH can also produce a wide base gait. Gait can be wide based in a short stepped, narrow basis in Parkinson's disease. Why in all atypical Parkinsonism as well as in NPH, you get a wide based gait with a normal AMC. So I'm telling that how to explain everything. See, it's not a simple case. That is why I'm bringing all the things together. We can explain the bilateral dragging, how to explain no pyramidal lesion, but you find a hydrocephalus. There is a lacunar infarct on the left side, what is right spasticity. Okay, that can explain that thing. Okay, but again, the reflex loss cannot be explained. For that, you have to think of diabetic neuropathy, you have to explain, or an unrelated radiculopathy. For the weakness of EHL weakness cannot be explained. That's why I did an air conduction. We should only that L5 route is affected.
So this dynamic spasticity is due to NPH or previous infarcts?
No. There is no dynamic. You mean to say what you're not getting in the spasticity? No, that's difficult to explain. Usually, dynamic spasticity you get in conditions like heterospastic paraplegia, old cervical spondylotic myelopathy is what a dynamic spasticity. Classically, HSPs. But that's not a bit. Sometimes, examination bedside, you may know only walking will pick up the spasticity. It's well known.
Sir, in that NCS study, I think there was good proximal pickup when TA was stimulated. Can that happen with L5 radiculopathy?
Yeah, because
compared
that
to
it,
EDP?
no, the thing is like that. He has got an EHL weakness. Okay, is it element or human? You have to find out. But we demonstrated that there is affection of the peripheral nervous system, either in the root or nerve, in the same muscle supplied by that. Okay. This is the way you have to approach then whether it can occur. You've got LM lesion or not. That's the first conclusion. I want to confirm whether it's LM lesion. What will you do? You do an NCS. NCS decrease in map amplitude of that muscle. But that means there is an LM lesion is there. Now, LM lesion where? Is it in the nerve or anterior console or root? That's the next thing. So look for a sensory conduct. Sensory conduction is normal. That's indirectly we are coming to the possibility of a root. It's not directly we are telling it that. This is the only way to approach a problem like this. In fact, then you may ask why it's only affecting that one particular muscle. That's difficult to explain. A radiculopathy or root involvement need not affect all the muscles, all the muscles in an equal fashion. That is when L5 radiculopathy, the only muscle affected may be EHL. That is the muscle you look for also. When you must have seen a number of dysplasia producing L5 radiculopathy. The only muscle affected may be EHL. All of the muscles may be normal.
Is it same with the peroneal nerve palsy? Because if there is a EHL weakness, the dorsiflexion of the angle should also be weak.
Yeah, in fact, in peroneal nerve palsy, that is what is called the commonest, the distribution muscle weakness is that supplied by that is tibialis anterior, EHL and dorsiflexion of the ankle. Most of the time, or not most of the time, in a good number of cases, the eversion will be normal because the fascicular vulnerability of the conperoneal nerve in such a way that the peroneal are spared. Those muscles supplied by the anterior tibial compartment, that is the deep peroneal nerve, is the most vulnerable part. So this is there in almost all the nerves. So I'll give some other example. If you take a sciatic nerve involvement proximally, the most vulnerable part affected is the conperoneal division. Next comes the tibial compartment, but hamstrings are still spared. Remember that point. Suppose you got a lesion the gluteal sciatic foramen, sciatic involvement, can totally spare the hamstrings. Even though single site, that is a site which should, if you cut that, everything should be lost. But that's called fascicular vulnerability. Same thing with radial nerve compression. You get only you get a finger drop of the middle two fingers. the extensor indices link may be spared. The other muscle, that's a more vulnerable one. So there is some vesicular vulnerability in all the nerves. In ulnar nerve lesion proximally in the cubital tunnel, you get invariably sparing of the flexor carpi ulnaris muscle. And middle part of the flexor frontal may be spared. Only the other muscles be affected first. And that too, in the small muscles of the ulnar nerve, the first muscle affected is the fourth palmar introsio. That is the first muscle. That is why you got the classical, this one, what's in Wartenberg sign. When that's a finger abduction sign where you put the hand in your pocket, the little finger will jut out. There is a first muscle affected. So such vesicular vulnerabilities, they're all the nerves. This you should keep in mind, especially in multifocal motor neuropathy conduction block. The patient may come with a funny presentation. I'll show one case later on. Only affecting the finger drop may be there, only the middle three fingers will be there. Other muscle may be normal. That's one peculiar, that's a type affection they can occur. So the sparing of some of the muscles separate can easily go with that in nerve distribution also. But the one which is classical of alpha radiculopathy is AHL weakness, sparing all other things. That is typical of AHL. That's called a segment pointing muscle. For example, C5 root, the segment pointing muscle is the rhomboids. C5 is supplying the biceps, deltoid, all separated supraspinatus, infraspinatus, all supplied with C5. But the one which is sole supply is for this is rhomboids is C5. That means if you got a C5 radiculopathy, you can't get affection of other muscles, sparing the rhomboids. Similarly, if you can L5 radiculopathy, you can have weakness of the hip abduction, you can have hip extension, you can knee flexion, dorsiflexion, inversion, all can be affected. But invariably, AHL should be affected because that is the segment point in the muscle, which is solely or almost solely receiving the L5 innervation.
In C5 radicular lesion, can we get a total weakness of a deltoid?
No, another point you remember that a monoradiculopathy, if a single root is affected, will hardly ever produce total weakness of any muscle. Except for something like even EHL also, they'll be affected, but not 0. You get a total affection if you can take any muscle, you think away from a root involvement. Because always in all the muscles have got more than one root innervation. Except some muscle like
I had a patient recently with a severe weakness with deltoid 0 power. And supraspinatus is also weak, infraspinatus also weak. And MRI was showing, rhomboids was preserved. MRI was showing a large disc at the C4, C5 level.
Yeah.
So that is 3 days duration presentation. So the surgeon was planning for a discectomy. But at that time, NCS and EMG will be negative also. So how to proceed such case?
I'll tell you, you got a good question. A total weakness of the deltoid, and you said infraspinatus, supraspinatus, correct?
Yes, sir.
Correct.
Yes,
what
sir.
about biceps and brachioradialis in that patient?
Biceps also mildly weak. Brachioradialis, I don't remember.
Biceps is relatively preserved, no?
No.
Relatively
mildly weak.
But mildly weak. That means relatively preserved. That pattern is not like a C5-C6 radiculopathy. Because a C5-C6 radiculopathy producing a total deltoid weakness should invariably produce significant weakness of the biceps also.
Maybe brachial neuropathy.
I'm talking sort of. That particular pattern is more like a brachial neurologic amyotrophy, what your patient is. And especially
so that is a clinical diagnosis, or how to confirm, because MRI plexus also done with the initial diagnosis of this one brachial neuritis.
MRI will not pick out any abnormality in the neurologic amyotrophy. It is a clinical thing. It is very often happens in clinical practice. So you say some weakness, you find some disc prolapse there. That may not be responsible for that in that particular patient. Finding, see many times this case, In fact, I'll tell you one patient who had in fact, I initially diagnosed diabetic amyotrophy. Subsequently, it came with worsening. I went to another doctor. I was not leave on that. I went to the neurosurgeon. Neurosurgeon found a large disc. See, large disc between L2 L3. And he was operated. He did not get any benefit. But the clue was that he had hip flexion was weak. The hip flexion weakness will not occur with L2-3 radiculopathy because the cardiac analyst will not produce that thing. That means just be plexopathy. What he had was only plexopathy. He improved it, made that producer later. So what I'm trying to say is that you may find disc protrusion in many individuals. Always when you find finding, try to think that whether that can explain the findings in this patient. Surgeon will immediately, surgeon is waiting for some disc to be seen. Whether it's corroborating with the clinical finding or not does not matter. It is for your responsibility to tell them that this cannot be explained by that thing.
So all C5 radiculopathy, invariably rhomboids will be weak.
Yeah, invariably rhomboid has to be weak. Because that rhomboid is solely separated by the C5 root, largely separated by the C5 root. Then I told you monoradical cell lymph is totally weak, except some rare instances like rhomboids. All of the nerves you take, it's got a multiple root contribution.
Okay, thank you.
Okay. Shall I go to the next case? Yeah, please.
Sir, in this patient had atrophy, sir. Can we bilateral atrophy was there, sir, in the brain? Can we call this patient as NPH, sir?
Yeah, that you got a good question. But here the atrophy, the ventricular dilatation is out of proportion to the atrophy you see there. And moreover, the symptomatology is also favoring NPH. Just by looking at so you can explain the symmetrical weakness due to that, but the perseverance in micturition and dragging slowness of the gait, etc., more likely NPH only. If you tell me why can't be a multi-infarct state, it could be that also. I cannot say no.
The CSF tap test was positive for this.
In fact, I called him for a CSF tap test because he is not bothered about it. He says that this has been there for long. I came him. He went away. Then I told him that if he is not improving, your perseverance is not improving, you please come back. I will be a tap test. He said he will come back. I don't think he's going to come back.
Any role for diamos for such patients?
No, absolutely no role for diamos for NPH.
Why, sir?
Pardon?
Sir, why diamond does not work?
No, theoretically, or it can decrease the CS secretion and all. But I have been even diamos for many years. None of them had any improvement.
Sir, this patient had any cognitive disturbances? Any memory?
He did not have any cognitive impairment. That's a funny part of it. Absolutely no cognitive impairment.
So any third ventricle dilatation is there, sir. Can you show the MRI, sir? Once again.
Yeah, okay, sure.
Are any role for CSF flow study?
CSF?
Flow study, CSF flow study.
Yeah, there is a role for CSF flow studies, but these are not absolutely foolproof. Sometimes in a flow study may be normal. Still, I see patients start improving with this thing. I'll show this T2 weighted. Sorry, it's not coming. Just 1 minute. It's come. Just 1 minute. Third ventricle also dilated. Okay.
Thank you, sir.
Okay. Shall we go to the next case?
Sir,
Yes.
MRI is a very classical NBH. And the radiological, the pathognomonic of NBH is DSA. It is classically present there.
That is there. What you said is correct. In the circle, if you look at the topmost cut, there is no, the brain is filling that thing. Below that, there are a lot of dish can be seen.
Callosal angle measures.
That is not going to help us much.
DSA is the classical finding.
Yeah.
Dash, no?
Dash. DESH. Now I'll go to the one. This case is given by Dr. Srinivas from Karimnagar. It's a 52-year-old female. This lady came with a history of acute onset of ataxia of 2 days duration. No other complaint. Look at the video of the patient. It's got look to the left side. It's got a jack nystagmus beating to the left side. No nystagmus could be seen on looking to the right side. In the primary position, occasional mild beat to the left side. Looking up, there is an upbeat nystagmus. On convergence also, you can see the upbeating nystagmus. And you can find out the jack nystagmus look to the left side, not present on look to the right side. Now it's making an occasional horizontal the primary person also beating towards the left side. So, what are your observations in this patient? This is only finding we apart from gait ataxia. No limb coordination. What do you think is the possible site of lesion? It's not a gaze-walk nystagmus. Nystagmus beating only to one direction, to the left side, or looking to the left, and occasional horizontal left beating nystagmus looking in the primary position. Mainly looking towards the left side.
Brainstem pathology.
Okay, brainstem. Why can't be a peripheral vestibulopathy?
Vestibular nuclear connections.
Okay. You could eject nystagmus beat to the left side, not particularly to the right side. This is a classically situation of a labyrinthine nystagmus. The acute labyrinthine nystagmus, grade 1 or grade 2. Grade 1 means only on looking to the contralateral side. Grade 2 means contralateral side plus looking straight. Grade 3 means even looking to the same side. This, if you find that nystagmus, typical of a peripheral labyrinthine nystagmus. Okay. But why not peripheral nystagmus here? There is a definite point against peripheral vestibular nystagmus. If you find such a nystagmus,
upbeat and downbeat. Upbeat and
correct. That's the point. You will not get an upbeat nystagmus in a unilateral labyrinthine nystagmus. You will not get a downbeat nystagmus in a unilateral labyrinthine nystagmus. You can have a horizontal nystagmus, horizontal rotary nystagmus, unilateral labyrinthine nystagmus. So if you find only a horizontal compartment, you have to think two possibilities. One is a peripheral nystagmus or a pseudo-vestibular neuritis. Pseudo-vestibular neuritis is that, where do you get that? Something mimicking a peripheral vestibulopathy, medullary lesion. Medullary lesion can produce a unilaterally beating only to one direction, no direction changing, not gaze evoked, can occur with the lateral medullary syndrome. And that is called pseudo-vestibular neuritis. So, but in the brainstem, why in the brainstem? Patients can have upbeat nystagmus. Now, where in the brainstem is that slightly likely lesion?
Brain.
In midbrain, how do you get that pseudo-vestibular nystagmus? Nystagmus beating only to one direction. Horizontal nystagmus. Upbeat, I agree with you.
Pontomedullary.
Correct. That should be in the pontomedullary junction. Correct. Perfectly right. Okay, medullary or pontomedullary region is the one indicated pseudo-vestibular nystagmus. Now, can the pontomedullary produce upbeat nystagmus? Yes. Let us see. This is the, what do you want now?
MRI.
MRI is, what do you find here? Lesions, this is on the left side. Another lesion on the right side. This is on the right side. I'll show that. This is on the left, present in both and right and left. What is the diagnosis here?
Cavernum.
Multiple cavernoma. Now, so what is the culprit lesion is on the cavernoma on the right and left side, but this is the culprit lesion on the left side. That can cause a pseudo-vestibular nystagmus as well as an upbeat nystagmus. Now, just for this slide I have shown before, but just for the beginners and also to refresh our old memory, I'm just telling don't talk about the pathway for the superior canal so that we can understand the pathophysiology of the upbeat nystagmus. You know, the anterior semicircular canal or the otherwise called superior semicircular canal get connected with the upward moving muscles, the muscles which may take the eye upward. The posterior canal or the inferior semicircular canal get connected with the downward moving canal. Inferior, upward, superior. Just remember that thing. So from the anterior semicircular canal, it go to the vestibular nucleus, superior vestibular nucleus, and ascend to the ventral tegmental tract and connected with the upward moving nuclei on the opposite side. The upward moving nucleus is what? Inferior oblique and superior rectus. So superior rectus, as you know, get connected on the contralateral side. Ultimately, it innervates the ipsilateral superior rectus. Inferior oblique supply the same side. So contralateral, inferior oblique. So if you stimulate the right anterior canal, the right eye goes up, right superior rectus is activated, and the left inferior oblique is activated. Both are going to move the eye upward. But the right eye means it goes up and in dot because superior rectus is an in dot. Here, the supplying the inferior oblique is again make the eye go upward, but it's an extort. So it makes the stimulation of one anterior canal make the eyeball move upward, but the dorsal movement is to the opposite side. This is slow moving upward and dorsal move to the opposite side. Now let us stimulate the contralateral side. It produces the same thing on the opposite side, however. So if the left-sided anterior canal is stimulated, what happened to the right side? The contralateral eye move upward and extort. The ipsilateral goes up and intorts, just like the other one. Only thing is happened on the other side. So what is happening? The net effect of stimulating both sides is it makes the eyeball move upward. But the dorsal movements are opposite side. One is moving up, intorting, one is extorting. Here also, one on the left side also, one is intorting and one is extorting. So the dorsal movements are cancelled out. So what you get is a pure upward drift of the eyes. So if you get that occurs only when bilaterally stimulated. Okay, unilateral stimulation will not produce this thing. So it will produce a torsional component. So here the torsional components are phased out. Only the eye will drift upward. That's a slow movement upward. So when you stimulate this thing, you get a slow movement upward. Suppose there is a lesion here in the midline region. The central ventral tegmental tract lesion is affected. When the fibers are crossing, you get the slow movement is reversed. Otherwise, taking up the input from the posterior canal is taking the upper hand. So the eye drift downward. This is slow component. So when there is a lesion, the slow component is downward and you get a fast component upward. That is what is happening in a responsible for the upbeat nystagmus. This is another diagram showing that the vestibular nucleus is connected with the VTT through the superior rectus, lesion will produce a slow phase downward and upward. This is a complete circuit. This is the thing which I already told on the superior vestibular nucleus through the VTT ventral temporal tract, go to the upward moving muscle. Even only with superrectus is shown, but also showing the other opposite inferior oblique also. This superior vestibular nucleus is inhibited by the flocculus. This flocculus is in turn inhibited by the caudal medulla. Okay. So if you get a lesion of the flocculus, in fact, the inhibition is taken on, this will be overacting. Lesion is medulla is there, not happen, the inhibition is taken off, the flocculus inhibition is over. Again, it is something like a destruction of the VTT pathway. So if there is a lesion here, what will happen? The inhibition is taken off on the flocculus. The flocculus is now allowed to exert extra inhibition on the superior vestibular nucleus. So it is equivalent to a lesion in the ventral tegmental tract. Again, you get upbeat nystagmus. So upbeat nystagmus can occur due to lesion in the midbrain, in the middle part of the brainstem, which affects the VTT bilaterally, or a lesion in the caudal medulla. Okay. And one more thing, remember that superior vestibular also directly will also produce stimulation of the caudal medulla. This is stimulation. So lesion here also will produce a upbeat, is equivalent to inhibition of the medulla. So upbeat nystagmus may be attenuated by convergence. I forget about that thing. It may even come again. You can measure. The point, remember, is that in medullary lesion, the amplitude of upbeat nystagmus increases on downward case. The commonest site is upper midbrain. In upper midbrain lesion, the upbeat nystagmus increases in amplitude on looking up. Suppose you find the amplitude increases on looking down. That upward nystagmus amplitude increases looking down. Think of a medullary lesion. So look at this child, for example. He's got a medullary lesion, cavernum in the medulla. Sorry, why it's not working? So there's some problem. Okay, I'll show the video. I did not copy from that the video file. That's the problem. Anyway, so the upbeat nystagmus is seen characteristically in upper midbrain lesion, but also can be seen in pontine ventral tegmentum, can be seen paramedian tegmental caudal medullary lesions and lesions anterior vermis and thalamus. The presence of concurrent oculomotor abnormalities may help to localize lesion response to the upbeat nystagmus. If you have a saccadic ipsipulsion and a skew deviation, such as a medullary lesion. An INO indicates a pontine damage. A vertical gaze pulse suggests a mesencephaly dysfunction. So the associated abnormality in the eye movement abnormality can help to localize where the site of lesion is. So our patient has left lower pontine lesion. How to explain this upbeat nystagmus? This is by the lesion here. As already told before, the superior vestibular nucleus normally activate the caudal medulla. There is a lesion here. It is equivalent to a lesion in the medulla. So you get a medullary lesion can produce upbeat nystagmus. This is from the literature. So various sites of lesion can produce upbeat nystagmus. It may be in the thalamus. It may be in the midbrain. It may be in the various sites in the pons. These are all various pontine lesions can produce upbeat nystagmus. It can be in the medulla. Okay, that's all the case. Just what I mean, whether I got a video is there or not. So that particular video is not here in this file. That's why it is not playing. It's not there. I'll show you next week.
Okay, sir.
Okay.
Sir, can you show the nystagmus again, sir?
Yeah, please. I'll show you.
Sir, one doubt, sir. In midbrain lesion, upbeat nystagmus amplitude increases on looking up, sir?
Correct.
Okay, sir. Thanks.
In fact, if you give me 1 minute, I will pick up that video and show you that particular one. Let me see. Before that, I will show this video once again.
వేలని చూడు వేలని వెళ్ళి వేలని చూడు వెళ్ళి ఇటు చూడు మళ్ళీ కింద చూడు మళ్ళీ మీరు చూడు వేలని చూడు ముందు ఇట్లా చూడు.
Here on look, convergence also it beats upward. And probably looking down is the element which is producing the upward movement.
వెళ్ళి వెళ్ళి మంచిగా వెళ్ళి మీరు చూడు కింద చూడు మంచి తల మంచిగా పెట్టు కింద చూడు ఒకసారి
Okay.
Thank you, sir.
Okay. Shall we close?
There were two lesions bilaterally, sir. Two lesions were there.
In the MRI, there are two lesions. Yeah.
So why you say, sir, only one lesion is responsible?
Yeah, usually that is the area, that is the lesion where the hemorrhage has occurred. See, this Kavanama has been there for long, no? But it present acutely means that some bleed must have occurred into that particular Kavanama. That will manifest their symptomatology. It so happened that it is a left-sided cavernous lesion. Kavanama has blood.
Okay. Sir, was she having any headache or something?
No, that part I am not very sure because this is not my case. This video was sent by Srinivas.
And the last one is the culprit. Then the nystagmus direction should be to right side, no? In vestibular.
No. That is no. In the case of what you said is correct. In the case of pseudo-vestibular nystagmus, it is usually to the contralateral side. But it can beat only to one direction also. Yeah, it can also beat onto one direction also. Usually, what is to the opposite side. What you said is correct.
So here the culprit lesion should be the
on the right side. Yeah, here in the lesion is on the left side. It's got both sides. No, the culprit lesion must have been on. Can explain by either way. Say here, since the pseudo-vestibular nystagmus is opposite side, most likely the right side one is the one culprit lesion, not the left side. What you said is correct. Classically, the pseudo-vestibular nystagmus is to the opposite side, just like mimicking a vestibular nerve involvement. In classical labyrinthine lesion on the left side, the nystagmus is to the right side. That is a classical peripheral nystagmus. In pseudo-vestibular nystagmus also, in left side, think about left lateral memory syndrome, the nystagmus is to the right side. Here, so must be the bleeding must have been here onto the right cavernoma and not on the left cavernoma. Because this cavernoma is there on both sides. The almost exact localization. Let me see that location, a picture once again. Yeah, it is there on here also on the right side, one is on the other side, correct. Which one must have been? Must have been the right side one. Any questions? Okay, shall we stop here? One important other clue clinical finding out to look for is when you get to differentiate whether it's a medullary infarct or it's a suppose a patient comes to you with imbalance while walking and vertigo, you find a nystagmus like this, mimicking a peripheral nystagmus, beating only to one direction, maybe due to peripheral vestibular or a pseudo-vestibular neuritis. We could know that somebody acute phase vestibulopathy can also produce mild ataxia falling to the same side. Okay, so in that case, how to differentiate? Another thing you would look for what? The saccadic lateral pulsion. How to look for secondary lateral pulsation I had shown before. Ask the patient close the eyes and then open. You find that eyes will move from the pulsed side to the primary position. So in this case, if the right-sided medullary is affected, then ipsi pulsion to the right side. So when you close the eye, eyes has already gone to the right side. Open it, will come back to the midline. Okay.
Pointing muscle, sir. You told
Pardon?
C5 is rhomboids, then L5 is EHL.
EHL.
Segmental pointing muscle. Any other?
Segment pointing muscles.
Yeah. Any
Many
other?
muscles do not have a single root. These are the two important muscles. Largely single root is applying that. Majority is applying the single root.
For C6, which is the muscle, sir?
C6 has got a multiple, there is no muscle which is solely separated by the C6. Either it is separated by C5, C6 or C6, C7. If you take pronated teres, it is C6, C7. If you take biceps and delta, it's C5, C6.
Can we get a C7 lesion or
No,
triceps
isolated.
triceps weakness with the C6 side of it?
In fact, triceps can have contribution, mainly C7, contribute to C6, even C8 also can contribute to triceps. But main contribution is from the C7.
One patient had a C5, C6 disc disease with triceps weakness and absent triceps reflex. Is it due to a prefixed this one root or due to a from C6?
The prefixed and posterior is only for the brachial plexus. If they got a radiculopathy, that does not matter. Root involvement means it is affecting exit from the exit foramen is affected. But so that way. Okay. If the contribution is coming largely from that side, that you can explain. Yeah, what you said is correct.
Sir, one question, sir.
Yeah, please.
Sir, if we get the skew deviation along with nystagmus, it is most likely due to the central pathology, is not it, sir?
Yeah, perfectly right. That's a point in hints also. But rarely it can describe in acute peripheral vestibulopathies, but hardly ever that is seen. Theoretically, it's possible because the input is coming from the otolith organs. Otolith organs are in the periphery. But in the practical situations, if you find a skew deviation, it is a central lesion.
Thank you, sir.
That is what is the hints also. Hints is head impulse test, no? That is head impulse test include head impulse tests, skew deviation, and what is the other thing? Nystagmus.
Nystagmus.
Correct.
So one more doubt.
Yeah.
Even though saccadic lateral pulsion is seen in central lesions, it may not be seen in all central lesions, isn't it? Is it so?
It need not be seen all in central lesions. That's the point. It need not be seen all central. It only depends upon, it is affecting that FOR. FOR means vestigial locomotor region, and
it is there, then that is central.
Yeah, that or its hook bundle pathway is affected, then it will produce saccadic lateral pulsion. If that area is not affected, the point is that if it is there, of course you can help.
It is central. Okay, then you need not search for anything.
Correct, exactly. Just like we do hints. So in fact, hints plus I have expanded. Hints plus hints is only 3, no? Skew deviation, nystagmus, and head impulses. So hints plus is including plus deafness as well as ataxia. So I excluded one more, that is head impulse, this one, saccadic lateral pulsion.
So hints plus 3.
Plus. So all the things can help. I had a patient. This problem came with acute vertigo. By the time patient is improved, only thing was only this kind of one set nystagmus, whether it's peripheral or central, we do not know. Because it's short duration. MRI did not going to help us. And patients have already improved. But this finding was positive. the head secondary lateral, but that made us confirm that it's a medullary lesion.
Okay, sir.
Sir, one more doubt. Sir, that
Yeah.
nystagmus, the amplitude decreases on looking down, then the lesion is in the medulla, is it, sir?
No, the other way around. The amplitude increases on looking down is medullary lesion. Usually in classical midbrain lesion, on looking the upbeat nystagmus, the amplitude increases on looking up. In medullary lesion, the upward amplitude is more on looking down. Contrary to what you get in upper midbrain lesion. Now, next class, I will show that typically this particular video somewhere is not working. I will show the next class.
Okay, sir.
Thank you, sir.
Thank you. Good night.
Good night, sir.
Thank you, sir. Good night.
Good night. Good night. See you
Wonderful
next.
class.
Thank you, sir. Good night.
Good night. Good
Wonderful
night.
class, sir. Thank you, sir.
Good night. Good night. Thank you all.
Good night.
Good night.